We have had some questions from Thomas in Germany, so I'll just forward them. And yeah, invite others to raise any questions in the chat if needed. So thank you both, Tony and Trish, for your great talks. So Trish, Thomas raised this first question about the remote by default, the new normal question mark. So do you promote this to be the new normal, or is it just an addition to the old normal?
So the kind of research I do isn't normative research. It's not, I don't do research to find out what should happen. I'm much more interested in what does happen. So we put in the question mark when we applied for the research money, the new normal question mark, because we didn't know. We were in equipoise. You know, we applied for this money at the beginning of 2021. The study started in the middle of 2021. And at that time, if you remember, we'd had this really rapid change at the beginning of 2020, or, you know, March, April 2020, where primary care just went digital. And that was on the back of various developments. People have been talking about the digitalization of healthcare and how it's going to make everything more efficient and modern and all this kind of thing. And then the pandemic came and we had to go digital. One of my PhD students is a GP, and in March 2020, her receptionist died because someone came in and coughed on her, and then she was unlucky. And that, I remember, do you remember that whole thing of we must go digital, we must be digital by default, remote by default. And our remote by default 1 study was looking at what happened in those early weeks of the pandemic, and whether you could assess someone with COVID over the telephone. So remote by default 2 built on that, saying, hey, it's a year later now. Things are going back to normal in a lot of places. Kids are back in school. We can go on the train again. We can go to a concert. We can go to a restaurant. Are we still going to be remote and digital in primary care? Because many people didn't like it. And also, it was not more efficient. In many areas, it wasn't more efficient. We had lots of double handling. We had staff stress, et cetera, et cetera. And so we were genuinely in equipoise as to whether this would be the new normal or not. So what did we find? And I didn't really explain because I didn't want to go over time, that the 12 practices that we were studying had a very wide range of what happened. So in the most digitally advanced practices, guess what? They became even more digitally advanced. Their pathways became more sophisticated, the technologies became more sophisticated, and those practices were generally serving a patient population of young professionals who all had smartphones. They were all very digitally literate, and actually they didn't have many sort of chronic illnesses or even acute illness. You know, they were the young professionals. At the other end of the spectrum, we had some practices either serving very disadvantaged populations or very remote practices, or practices serving predominantly elderly people. We have one in Oxfordshire where a lot of people retire to this particular village, and with all these practices that they wanted to reintroduce the face-to-face by default. But one of the really interesting things was most practices in the middle of our sample were doing both. They were having a hybrid service, and they were getting better and better at kind of providing the kind of package that each patient needed. It wasn't that simple, but only 1 or 2 practices said we're not doing any digital, and only 1 practice was hardly doing any face-to-face. Most of them were in the middle, and they were kind of trying to achieve a balance. So I would say it's not remote by default that's the new normal. It's hybrid provision with flexibility for different kinds of patients.
Thank you so much, Trish. And I think this actually answers the second point raised about Thomas again being worried that healthcare, when it becomes more accessible digitally, patients may contact healthcare providers more frequently for minor issues that they could have managed themselves, and that could, of course, potentially lead to overwhelming healthcare systems. But yeah, it seems that they found some other strategies. They picked up hybrid formats down the road. So very, very interesting.
Yeah, we definitely found that the increased accessibility through remote, it's very straightforward. I'll tell you a story because I think it's quite illustrative. So a few weeks ago, I overdid it at the gym, and I got what was probably costochondritis. So my ribs were hurting. And I wanted this particular medication, which a colleague of mine who is a sports medicine doctor, you must get this particular anti-inflammatory drug. So I sent an e-consultation to my GP. And one of the questions on the algorithm was, do you have chest pain? And of course, I said no. Because if I knew that if I'd said yes, I would then be told to go to A&E, because I knew, because I have high health literacy, that even though I had really bad chest pain, it wasn't the kind of chest pain that the algorithm was thinking about. And so I was able to send this message to my GP, and very quickly I got my medication. But actually, the next day I felt better anyway. I hadn't even picked up the medication. So I didn't really need it. I had a self-limiting condition, but because I was in that demographic, I did my request, and the GP responded to it. Which patient lost out on a GP consultation because I took up that space? That's the problem with remote, and I think we need to educate the patients.
Thank you for this wonderful story. Mark, you have something to share as well, or some resources?
Hi, yeah, thank you. Just Thomas's question around, in Scotland, we have a raft of online tutorials and resources for people to access. So I can send you the link. You'll be able to access some of it, but not all of it. But I'll give you an idea of what we've been able to create in Scotland to empower our clinicians to learn about how to do digital, because it is different. There's nuances around communication, the subtleties around rapport, all that kind of stuff on a remote consultation. So anyway, I'll put the link in the chat that only you and I can see, and hopefully you can then transfer it to the public chat. Thank you.
We can display it afterwards, no worries. Thank you so much for providing that. And that is a reply to the third point, being that whether there are any training for online consultation resources available. And yeah, we are definitely interested in Denmark as well. So yeah, please share, Mark. Tony, you have a final comment, and then let's move on to the flash talks.
Yes, I just wanted to make a reflection, and this is, as you know, so we are working in 53 countries plus, because sometimes we go to other WHO regions. And when you discover what they haven't got in those countries, then you say, wow. So, and then I would like to say that it's better to have these digital solutions available, because it's a choice. And this is something that you could make. It's a choice sometimes. And for some other people, it's not a choice. They are obliged. If there is a mountainous area, so countries that 80% of their facilities are above 2,000 meters, or if you go, as I said before, to Lapland, where is the size of half of England, and there are only 200,000 people. Those people, to have access, they need some digital solutions really benefit the access of those people to that. So it's very contextual. But if you haven't got it, so then you despair. So I've been in different countries, living in different countries, saying, my God, I haven't got access to the patient's portal, for example. And I was used to that. So you miss when there isn't, But the good thing is at least to have the choice, and that is fitted with the health system you work. So it's not just an anecdote. So we were contributing with a country that they deployed telemedicine devices in rural areas, very remote rural areas, and the facilities didn't have water and didn't have access to internet, but the devices were there. So, and this is something, that's why I brought into the discussion, there has to be a very, very good strategy behind and not doing things ad hoc, you know. And because normally the best vendor, the one that convinces you most in some countries, is the one that allocates and deploys some devices there. So I would like to send this message because this is relevant and this is what we encounter in many, many countries. So over from my side, and it's been a pleasure to contribute to this discussion.